Great, thank you, Jorg. And don't worry about the title. I'm still getting used to the new title myself. Just Mark is good enough anywhere. So I'd like to take this opportunity to share some of our learning as we have crossed boundaries to create research clinics and enhance the impact of the findings of our clinical research in Sussex Partnership. I will anchor this presentation around the Sussex Voices Clinic, an environment where we try to increase access to evidence-informed interventions by practicing in innovative ways, whilst continuing to learn from routine data collection and learning from research studies as well. This picture could represent the gap between research and practice in many clinical fields. In my field, it represents the gap between the recommendation by NICE that all psychosis patients should receive a course of cognitive behavior therapy, and the clinical reality, as reported by the Royal College of Psychiatrists, that only a quarter of our patients are offered this intervention. The primary reason for this shortfall being limited resources, as CBT should be offered over a minimum of 16 sessions and is typically delivered by highly trained therapists, usually clinical psychologists, and they are in short supply. Our initial attempt to increase access to CBT was to develop and evaluate a novel group therapy, person-based cognitive therapy, which combines mindfulness and CBT. And a group therapy, of course, will allow a number of patients to be simultaneously treated by the same therapist. So a series of trials culminated in a definitive trial funded by the NIHR RFPB program. And the M4V trial generated positive outcomes. And we were keen to offer the groups to our patients in Sussex Partnership as soon as possible. We really wanted to close the gap between producing these findings and changing practice. So this could have been achieved by trying to persuade the managers of our community mental health teams to commit their resources to the organisation and delivery of these groups. Or we could cross service boundaries and make them a more attractive offer by sharing resources. And that's what we did. We proposed that the highly trained therapists within the clinical service deliver the group intervention, that researchers within the R&D department train these therapists and offer them clinical supervision, and jointly funded clinic assistants undertake all administration and assessment tasks. So combining our resources to make possible that which might not happen unless these resources were combined in that way. So that combining of clinician time, researcher time, and jointly funded assistance, oiling the cogs around the delivery of this evidence-based intervention, acknowledging that the clinicians wouldn't be able to do all of that given their limited resources. So we negotiated with managers at the community mental health team in Brighton to pilot this approach. And the therapy was to be offered by a team of 6 highly trained therapists in the first instance, most of whom were clinical psychologists. So mindful of the interpersonal sensitivity of many of our patients, we offered an evidence-informed one-to-one brief coping intervention prior to the group, a bit of a warm-up, an opportunity for patients to talk about their voice hearing experiences, possibly for the first time in a safe one-to-one space, and then moving on to the group. So we were offering an intervention pathway that was consistent with NICE guidance that patients should receive a minimum of 16 sessions. So our initial outcomes were encouraging, as we noticed a stepwise reduction in voice-related distress, which is our primary outcome, and we decided to extend the service by moving along the coast to Eastbourne. However, away from the bright lights of Brighton, the Eastbourne team had very few highly trained therapists. So from the outset, we needed to support a broader array of frontline practitioners to deliver interventions to this patient group, primarily practitioners without any therapy training. And the clinical governance criteria would not allow these briefly trained therapists to deliver the group intervention without extensive training. So in order to cross the workforce boundary, we needed to develop an intervention that could be delivered by briefly trained therapists, without, of course, compromising the benefits available to our patients. So we took our self-help book in the top left-hand corner of the screen called Overcoming Distressing Voices, and we turned it into a workbook-based intervention that could be guided by briefly trained therapists. So the so-called Give intervention is offered over 8 sessions, with each chapter in the book linked to sessions and modules within the therapy. Before putting this intervention in the hands of briefly trained therapists, we wanted to evaluate the experience and outcomes when the intervention was delivered by highly trained therapists, such as myself. And the findings showed a surprisingly large between groups effect size on voice-related distress, something we were quite surprised by. And so we moved on to the briefly trained therapists. Having had this kind of proof of concept study, we wanted to take the therapy from the so-called masters, give it to the apprentices, and see if the benefits for patients were still apparent. Given the diversity of the mental health workforce, we sought to identify an appropriate part of the workforce that could help us to evaluate the Give intervention. We considered case managers, but were deterred by the literature suggesting that whilst they can enthusiastically receive training in the delivery of a CBT for psychotic experiences, they often lack the time to deliver interventions within their busy case manager roles. So graduate psychologists, often called assistant psychologists, they seem to be better positioned as they are trained in models of behavior and emotion, are widely available, cost effective, and don't carry case management caseloads. So this was the workforce that we identified who could help us to evaluate what happens when we offer this novel Give intervention to patients distressed by hearing voices, psychosis patients distressed by hearing voices. It is interesting how when we conduct research, we're often encouraged to work more narrowly with well-defined homogeneous groups of people, whereas of course in clinical practice, it's often a lot messier and heterogeneous than that. So with the support of the RDS, we successfully applied for funding to conduct a 3-arm feasibility RCT, comparing the Give intervention delivered by assistant psychologists with an active control condition and treatment as usual. Our first feasibility question concerned retention. Would participants be willing to stay in the trial and offer data at 16 weeks post-randomization? And we had an affirmative response, as retention at 16 weeks was 86%, meeting our progression criteria. We plan to collect follow-up data from only those participants who reached the 28-week post-randomization milestone before the end of the data collection period. And retention was 74% at 28 weeks, slightly below our progression criteria. However, as the background to the slide suggests, the final 6 months of the trial was conducted during the COVID-19 pandemic, and this may have influenced retention. And it is pertinent for me to once again thank the research team for their fantastic efforts to complete the trial, recruiting to time and target, despite the pandemic trying to throw us off target, as it were. In terms of feedback from participants who received the Give intervention, people talked about their positive hopes and expectations of outcome for both Give and therapy more broadly. Their positive experiences of the therapy, and especially the therapists and the workbook. And that's important because these assistant psychologists don't normally deliver therapy to this patient group with complex needs. This is the paradigm shift that we're exploring. What happens when we take a psychological therapy, evidence-based with highly trained therapists, and give it to briefly trained therapists? Well, the patients who received the GIVE intervention in the trial said they were good. It was a good experience. That's important. And they also spoke about the positive impacts of the intervention as it provided learning tools, increased understanding, and changes in outlook. And of course, we were also looking to see if there was a signal of efficacy in favor of the GIVE intervention. And benefits in favor of the GIVE intervention seemed to be evident at 16 weeks relative to both the active control condition and treatment as usual, with effect size between groups effect sizes in the medium to large range. So having met our progression criteria, we again drew on the support of the RDS and were awarded funding to conduct a definitive RCT, the GIVE-3 trial, which began last month. So I'm looking forward to working with colleagues over the next 2.5 years to learn more about what the assistant psychologists can achieve when delivering this intervention to these patients with complex needs. Encouraged by the findings from these initial trials of the GIVE intervention, we have been training and supervising a broader group of briefly trained therapists as they have delivered the GIVE intervention within the Sussex Voices Clinic. And the pre and post outcomes across all of our data are interesting, as large pre-post effect sizes are evident, irrespective of who delivered the intervention. Highly trained therapists in the first GIVE trial, briefly trained assistant psychologists in the GIVE-2 trial, or a broader range of briefly trained therapists within the Sussex Voices Clinic. We didn't necessarily expect that. We expected maybe different therapists to generate different levels of benefit. So we'll keep an eye on this as our data sets grow. Having moved across service boundaries and workforce boundaries, we were keen to be inclusive of patients by working across diagnoses. Please excuse the postman just arriving at my door, the joys of home working. Voice hearing is traditionally associated with psychosis. However, voices are commonly reported by patients with a diagnosis of borderline personality disorder. But these experiences can be dismissed as pseudo hallucinations, not taken seriously and not treated. So we explored, my postman's very persistent, I will ignore her. We explored this issue with Hugo Critchley and colleagues at the Clinical Imaging Sciences Centre, and across multiple levels of assessment, including scans, found that voice hearing experiences for these patients were similar to the experiences of psychosis patients and required treatment. The need for treatment of voice hearing was also echoed by the participants themselves, who, in a separate paper, rated voice hearing as one of their top priorities for treatment, a higher priority than self-harm, which can be a priority for clinicians. So really interesting, when we listened to the voice of patients, they were saying, actually, this distressing experience, voice hearing, this is a real issue for us, a real treatment priority, possibly at odds with the priorities that clinicians might set. So the clinical need to work transdiagnostically is illustrated by the proportion of our referrals that are not related to psychosis. So this is an early cohort of 225 patients reported in the literature 3 or 4 years ago. And we see that about a half of our patients don't have a psychosis diagnosis, and about a quarter of our patients within the Sussex Voices Clinic have a diagnosis of borderline personality disorder. So there is clinical need. It's important that we work across diagnostic boundaries, but also that we conduct research to ensure that that is something that we should be taking forward. If voice hearing experiences are commonly reported across diagnosis, they are also evident across the lifespan. Indeed, voice hearing is most commonly reported by young people, albeit this experience can be transient. So keen to address the treatment needs of young people, we began to offer our short coping intervention within some of our CAMS teams. Engagement and outcomes were encouraging. And mindful of the presence of parents in this space, we offered them a psychoeducational workshop where they could explore ways of supporting their child to cope with voices. Outcomes from this workshop also offered encouragement, and with the support of funding from the CRM, we are preparing a grant application to evaluate the combining of these two interventions into one interventional package. However, as we consulted with young people about our plans for evaluating this intervention package in CAMS, they had different ideas. So young people within the Youth PPI Cafe in Sussex suggested that we offer these interventions within schools, not CAMS, thereby facilitating early intervention. They also suggested that young people may not want their parents to attend the workshop, and suggested that the young person nominate a +1 who they wanted to support their learning. And then when we consulted with young people at Voice Collective, a national charity, they suggested that the intervention package should additionally include a whole school approach due to the stigma experienced across the school environment. So this evening, we will be consulting with parents about their views, and next month, we'll ask similar questions of school staff. Lots of learning here for me about co-production and what it means to go into a space not knowing, with a genuine willingness to learn from those who do. We were also curious about the impact and treatment of hallucinatory experience at the other end of the lifespan, within the context of dementia. Thanks to funding from the University of Sussex and Research England, we've begun a consultation with people living with dementia and their carers about possible adaptations to our brief coping intervention. Interestingly, these consultations to date have suggested that we don't restrict our curiosity to voice hearing experiences, but consider hallucinatory experiences across the 5 senses, and that's what we'll be doing. As our crossing of boundaries within clinical practice generates many lessons, we are committed to sharing those lessons as widely as possible. This has resulted in many publications which, whilst not able to find their way into the high impact journals, are able to reach the clinicians whose practice we are trying to influence. We are indebted to Anna-Marie Jones, who has played a key role in the analysis of this often messy clinical data. Anna-Marie is our statistician and an RDS advisor, and I'm delighted to say that she has recently been awarded a PhD by Published Works for her work on handling and learning from clinical data. The paper that I'm most proud of amongst this collection relates to the group intervention that stimulated the creation of the Sussex Voices Clinic. Having offered this group to 95 patients within the clinic, we were in the unique position to compare our clinical data with that from the original trial, with findings looking surprisingly similar. Again, something we weren't necessarily expecting to find. The final boundaries that we cross are those belonging to countries. So we've been delighted to collaborate with the Perth Voices Clinic in Australia over the past few years, learning about the delivery of our interventions within a different healthcare economy. And in Europe, we are collaborating with colleagues who have attracted funding to evaluate some of our other interventions. In this instance, our relating therapy is being evaluated in Germany after NIHR rejected our application for a trial of this therapy in the UK. Finally, I'm pleased to say that boundaries no longer exist in relation to learning from the lived experience of our patients, and the Sussex Voices Clinic and all other research clinics within Sussex have a lived experience running through them like a stick of rock. Broadening the lens beyond the Sussex Voices Clinic, we now have 8 research clinics operating across Sussex Partnership. The first wave of 4 clinics, including the Sussex Voices Clinic, relied on R&D funding to build some momentum. I was quite happy to commit some of my budget to increasing impact. I'm pleased to say that the latest wave of research clinics have been recurrently funded by the Trust Board in recognition of the value added as we try to increase the impact of research. The final piece of data that I'd like to share comes from Curtis, a patient who received the group therapy back in 2016. Out of the blue, I heard from Curtis a couple of weeks ago. He contacted me from a mountain retreat in Spain, where he is taking mindfulness to a new level. And with his permission, I'm able to share the inspiration that I'm taking from his journey of recovery. And maybe if I just read his last quote for those who may not be able to see it clearly, he said, "So yeah, my life is completely different to anything I could have imagined back before the Voices Clinic therapy. And I really do think that coming along to it is where my life began to change for the better." So I'm really inspired by Curtis's journey and delighted that he believes that journey started with us. I hope I have offered some useful insights into the ways that we are working across boundaries in order to bridge the gap somewhat between research and clinical practice. There are so many people who have contributed to our learning along the way, but I particularly wanted to express my gratitude today to the NIHR RFPB programme for their funding, to the RDS for helping us to design fundable studies, and to the CRN for helping us to recruit well to those studies. Thank you for your attention. I'll stop there.
Many thanks, Mark, for a really inspiring talk and what is a great success story. And also, I think it's great that we have these close collaborations between the Sussex Partnership Trust and the RDS, our own organization, through who is now Dr. Anna-Marie Jones. So we have time for a couple of questions. Anybody would like to ask a question or comment? Please do use the hand at the bottom on where the icons are.
I'm just noting your Sharon's comment about really liking our inclusive approach with the young people's work. And I think, as I alluded to, it has been inspiring to travel into young people's work and also into the field of dementia, not fields where I've worked traditionally. And it's been inspiring to go into those places not knowing, with that genuine willingness to learn. And these co-production processes we're going through are both exciting, but a little bit unnerving, because I don't know what's coming next.
Yeah, I mean, just one observation before I hand over to Sharon. I think it's interesting that some years ago, while impact is now a topic of discussion for some years, but possibly when you started, impact wasn't such a priority as it is now. And it's interesting how, this shift in focus, and I don't know whether you want to comment on this somehow, what your reflection on impact is as part of all, reflecting on the work you did.
I think it has changed. I think it's an imperative now that we demonstrate impact and some added value to investing in research to our patients, and we need to make sure that impact is as immediate as possible. So I think there has been a shift. I think it was necessary. And maybe it reflects how I think the clinical research infrastructure supported by the NIHR family has helped us conduct, I think, really high quality clinical research. So maybe the delay has been that actually we needed to enhance the quality of the research, enhance the inclusive involvement of stakeholders in research. And then maybe once that camp was in order, we could then more genuinely seek to translate what we learn into practice. Maybe 20, 30 years ago, what was coming out of clinical research, maybe the quality was a bit more variable and there wasn't the imperative necessarily to translate. Now I think NIHR supported research is of a high quality. It must have an influence on patient care as soon as possible. So this conversation today is welcome. But yes, I think time has come to move what we learn into practice.
Thanks. Interesting comment and observations. Sharon, you wanted to ask a question. Is Sharon still there?
Hi, yes, I am here. Hopefully you can hear me.
Yes, we can. Thanks.
Lovely, thank you. The meeting disconnected for me briefly. I was just going to say, Mark, I was really pleased to hear about how you involved young people in the development of the clinic specifically for them. My background is in youth and children's work, and I now work as the patient and public involvement facilitator with the research team at QA Hospital in Portsmouth. And it's really heartening to hear how children and young people's voices are not just being heard, but acted upon in the design of research. It's really important in that age group that they feel they have some autonomy and that they are able to have some choice in how that care is delivered and how that research reflects their lived experience. So it's just a big thumbs up from me, and more of the same, please.
Thank you, Sharon. And I think it's really interesting with the young people's work to acknowledge the power imbalances within the systems within which they live. So we're meeting with parents tonight who have a lot more power than their children, and we're meeting with school staff next month. Again, there's a power imbalance between young people and school staff, but also between parents and school staff. So how we manage these power differentials as we move forward with our co-production is going to be really interesting. And we're asking people as we meet them, how do we manage these differences in power that exist between the important stakeholders? So yeah, lots to learn.
Thank you very much. So it is now 1:45, and we have planned a short break of 10 minutes. So can we all return in 10 minutes, or to be precise at 12:55 for the talk then by Dr. Julie Bailey?